Welcome to the centrepiece of the FREYER meeting. And I'm honoured and delighted to introduce Dr. Mike Ryan, Executive Director of the World Health Organization Health Emergencies Programme, who's going to do an in-conversation piece with me, and I hope you, over the course of the next hour or so, if you have the time, Mike, for that. And in introducing you, I guess it's fair to say you're arguably the world's best known living doctor at the moment, based on what the pandemic has done and how it's affected everybody. You're an alumnus of the college here. You're the inaugural Cameron Lecturer at RCSI. I know you're were a surgeon to start out, and you're involved in the global surgery program, I hope, currently and in the future with RCSI, in terms of where that will hopefully lead the world going forward. And I guess in starting out, right, I see, I'd like to introduce, ask people to put any questions they might have on the chat function as we go, but there's one that came up overnight from Professor Kevin Barry and Ronan Waldron, and it was along the lines of, will Mayo win the All-Ireland, and what impact will that have on COVID in the world? Now, before you answer that question, I'd just like you to maybe give us an overview on the current status of COVID and what's happening as you see it from Geneva at the heart of the World Health Organization program.
Well, when he came in on Rowan, going to ask a question like that, and I never knew you, might as one for hyperbole, but that introduction kind of overshot the runway in terms of my relevance or importance to anything. It's interesting, you know, looking at the global epidemiology. There's a kind of a sense of it's like in soccer, they think it's all over, and you know, people, I suppose, deserve that emotion. People have been through an awful lot. And a sense that the worst of this is coming to an end. It is becoming a reality in a lot of countries. I suppose the pressure of hospitalizations and deaths, patients been separated from their families, doctors and nurses and healthcare workers under immense strain. You know, those images are beginning to disappear from our television screens, and schools are reopening. So that sense of normality is returning. But, you know, we still have well over between 4 and 5 million cases a week. We still have 1 million cases a week in the European region. You know, we had 70,000 deaths last week alone. So therefore, the pandemic has sort of stabilized at a really high sort of worrying level. But I suppose the good news in that sense is that the incidence rate, the number of cases, that pressure of force of infection is becoming decoupled from hospitalizations, ICU admissions, and deaths. So what we're in a sense doing is, normally, historically, a disease will evolve into something less severe and settle down and become an endemic human disease. We have the advantage of technology that we can force the hand of the virus by introducing vaccination, and we can change the nature of our herd immunity by using vaccination to protect ourselves and others around. And in that sense,
can I ask you, in that space, Mike, how effective do you think the vaccination is globally at the moment? I mean, we're putting quite a huge store on it in this country. Globally, what do you think, or how do you think?
All of the studies show the vaccines remain very effective, you know, against the target that we designed. And it's a bit like in surgery or cancer services. You design a target and say, what do we want this vaccine to do? And the primary target of vaccination was to prevent hospitalization, prevent severe disease, and prevent deaths. And if you measure the vaccines against that parameter, they've been fantastically successful. When you think that in 6 months, you know, I mean, you know, the cycle for vaccine development, and you know it in cancer services, the holy grail is ultimately cancer vaccines in a sense. And we have them in a sense through HPV now and others. And, you know, how long did it take for the HPV vaccine to be developed, to be distributed, and to be rolled out and introduced into public health programs? You know, on the face of it, a life-saving, game-changing vaccine. It took decades. We've done that collectively between science, medicine, public health, the private sector, and governments in 6 months or a year. So in that sense, the vaccine has done exactly what it said on the tin. What it hasn't done so successfully is prevent transmission. And much of that is because of the evolution of variant strains. The virus is adapting, the virus is evolving, becoming fitter and fitter for transmission in human populations. It's doing what it says on the tin. And our technology and our public health response is fighting against that natural evolutionary process. And we're right on that cusp now, where the virus has become much more efficient. Our vaccines are not as efficient in preventing mild infection or transmission. So when you see that in countries with very high levels of vaccination, we continue to see very high rates of disease transmission, particularly amongst the young vaccinated. We've also seen the disease shift into younger populations with lower levels of vaccine protection. And we hope that as vaccination expands and those particularly sort of people in the 20s and 30s, that will also have an impact there. So that's the conundrum. But in terms of vaccine rollout, I mean, the great inequity of this pandemic is that life-saving intervention is not equally distributed around the world. And, you know, if we still have 10 countries have used 75% of the world's vaccine production, we still have a situation where if you live in a developing country, in a low-income country, you're looking at 0.3% of the vaccines available being used in those settings. So
is the COVAX program going to impact on that, do you think, Mike?
Yeah, I mean, COVAX works. I mean, the system works, the purchasing system, the distribution, the allocation frameworks, the work to support countries in absorbing those vaccines. The problem, and this has been characterized, fairly badly around the world as, we don't want to push vaccines into that system because people may want not to use them, or countries aren't capable of using them. That's been a sort of a narrative growing, and that's not the case. The problem is a supply problem. And, wealthier countries and, all countries are there to protect their own citizens. Governments are elected to protect their citizens. And there's been a huge amount of purchasing of vaccine from developed countries, understandably, and manufacturers have also prioritized sales to those countries. So there's been a huge distortion in the market. Now we're seeing that shift. We're seeing countries beginning to shift unneeded supplies, beginning to shift contracts into COVAX, beginning to make donations into COVAX. We're seeing increasing funds coming into COVAX, and that's accelerated. We had the unfortunate issue in the beginning for us that a lot of our vaccine purchasing within COVAX was with the SII India, the AstraZeneca vaccine that had been sub-licensed, and then India got hit with a huge wave. And again, understandably, the Indian government prioritized the production in India for India, and we lost a huge amount of production that was already contracted into the system. So we're adjusting for that. So we hope with everyone's support to see a massive acceleration in that. And it is a tragedy if we still have doctors and nurses in frontline situations in low-income countries who are not protected against COVID.
Is the Delta variant still the dominant one internationally? I was reading about a Colombian variant that's likely to be worse than it, that's kind of very high impact in Colombia currently. But from your point of view, just where you are, do you think there's going to be other variants that are worse than Delta, or what's your take on that?
Well, Delta is by far and away now becoming the predominant strain. I think it's 170 countries have reported presence and transmission of Delta strain. The variants, the variant, as you said, first detected in Colombia has now been called the mu variant. It's been around for a long time. And here we see the difference between what looks like a worrying genotype. The mutations in the mu strain are quite concerning, particularly in terms of vaccine escape. But phenotypically, it has not spread quickly. It has become a significant strain in Colombia. I think about 40% of isolations in Colombia that are reported are that strain. But we've not seen it establish itself significantly or transmit in the same way that the Delta variant has transmitted. And these viruses, they're competing with each other. So they're either going to gain attributes of transmission advantage, and that's a driven pressure. That's a non-random effect. That there's pressure in the system on the viruses to become fitter for transmission. That makes the virus more successful. There's a non-random effect, which is that effect to become more virulent. It's not necessarily in the virus's interest to become more virulent, but if you have just enough viruses replicating in their hundreds of trillions, there's a chance effect that at any point a more virulent strain may emerge. And that's what we're watching.
Compare, I mean, Corona versus SARS and stuff like that, just in terms of virus epidemiology, or for the innocent surgeon like me looking in. But what, like, how do they compare, or why did SARS, why did it come and go, or what do you think? Like, I suppose the question I'm asking is that, is the next coronavirus going to kill half the world's population, or will it kill itself out? Because if it's very virulent, that's what naturally happens, that the people die off before they transmit or some such. Is that
Yeah.
well?
It clearly, it's again a virus that presents itself with very severe disease and death has a huge impact, but it also shows itself very easily. So if the predominant number of people are very, very sick, you have a signal. It's like Ebola. If everyone with Ebola gets very sick and comes to hospital, then yes, it's a tragedy and it's horrific, but you see the virus through its expression in the human system pathophysiologically. It's when a virus has a significant proportion of people with mild symptoms or pre-symptomatic disease, where they can transmit before they become fully systematic. That's where the virus has the advantage, in that the next generation of cases are being generated before you can recognize this generation of cases. And coronaviruses are pretty good at that. The SARS virus, SARS-1, the one we all experienced in 2003, while it was very severe in those who were infected, it actually, the symptomatology presented, in a sense, people were not symptomatic before they became sick, or at least not before they showed symptoms. So we had an opportunity to, through case finding, contact tracing, and containment, to stop the virus. And remember, if you look back at SARS, we think SARS was a pandemic, or SARS-1. It wasn't. It was essentially, if you look at it, mainly a nosocomial disease, in which we had high rates of transmission in hospitals, where we had aerosol generating procedures. We had many health doctors and nurses exposed. And then there were unique situations like the Metropole Hotel and the Amoy Gardens, particular situations in which the disease spread in sort of super spreading events. But we never in SARS-1 had this massive community transmission. And the same with MERS. We didn't see this huge population-based transmission as the predominant representation of the virus. In this case, we saw that, and we saw that virus emerge and transmit efficiently from human to human at community level. When that happens, and a high proportion of people are mildly ill, that in one sense, that's a reassurance. Well, most cases are mild. And from a healthcare point of view, that's good news. From an epidemiologic point of view, you're not seeing the virus early enough to be able, unless you're super efficient with contact tracing. When you're super efficient in the public health arm of health, you have to be, you basically have to be, premier division sort of public health services to be able to pick that signal out from a community that's experiencing all kinds of other mild disease.
Talk to me about super spreading events in the context of a mainly vaccinated population.
We talk about, I'm glad you said super spreading events, because I don't like using the word super spreaders, which puts the responsibility on the person doing the spreading. I mean, super spreading events are really events in which we have a large number of people gathered together in a situation where there's a massive opportunity for disease transmission.
Would the population of Mayo be better off in Croke Park or in Castlebar next Saturday, is what I'm wondering.
I don't think the population of Mayo will give a damn where they are, as long as they bring home Sam. No, I mean,
but in terms of being outdoors, being in a football match, or
absolutely,
stadium,
look,
compared to, like, say, 200 people in a hotel room with poor accommodation, I'm just in your.
No, and again, it's relative risk. We do this. We're human beings. We're hunter-gatherers by nature, right? We're constant risk managers. We were hunting mammoths and hunting lions. You had to make a decision of the risk of taking an animal versus the benefit of feeding your family, right? Every time you did it. So human beings are very good. And I think we've underestimated the natural intelligence of people to absorb and process complex information. Risk is relative all the time. So one thing is less risky or more risky than another. If I'm gathering with people, if the number of people concentrated in a space is high, then the chance of transmission is higher. If I'm gathered with them outside, the risk of transmission is much lower than inside. If we're all shouting and roaring and singing into each other's faces, then the risk of transmission is higher. So there, and that's, it's like a risk. It's like an accelerator. It's like a dial where your risk during the day, during the week goes up and down depending on the activity that you're participating in. If the vast majority of people in a venue that's outside are vaccinated, right? And if there's good measures in place to manage that, then these events are increasingly safe because of vaccination. But I still worry that we have to be very, very careful with large scale indoor events where we have to have proper ventilation, proper spacing. And Ireland and other countries are now kind of moving from a phase of state-based intervention to much more self-directed behavior for managing risk. And that's an important transition. Because in one sense, people want their freedom back, and that's a good thing. And they want these, externalized restrictions to be lifted, but we still have to take care of ourselves. And in doing that, we have to just judge. If I'm a 75-year-old that's fully vaccinated, but I have 2 underlying conditions, I may think very differently about going into a pub, even if everyone is vaccinated, because there's still a small chance that it could be infected. If I'm a 25-year-old fit and healthy person who's fully vaccinated, that same activity has a completely different implication for my health. And people have to not just, it's not a linear process. And I think people are smart and they know how to manage that.
Okay. And then in terms of, you're saying vaccination and transmission, it doesn't really have the same impact, you think, or not?
Certainly vaccination reduces transmission. It reduces your risk of being infected, and it reduces your risk of passing that infection on to someone else. But like in all cases, the vaccines are not perfectly efficient at preventing a second infection if or primary infection. And part of that may be because people are processing the virus in their nose, they're processing the virus on their epithelia as such, and they're potentially not getting a full-blown corporal infection, and actually the rates of maybe very mild and asymptomatic infection are higher. But there's no doubt that it protects against infection, but not completely. And that means that the virus will continue to transmit unless we also maintain some of the other precautions that we have in place. So
talk to me about that in terms of what do you think Ireland is going to be like at Christmas or whatever in 3 months, 4 months time? Are we likely, this is, conjecture, but mask wearing in terms of indoors still on, do you think, into the foreseeable future?
I don't know. Ireland has to make, I'm not going to, lecture the Irish public health on what they do. Prudence I would say, if it's me, and I would be saying to people, maintaining some form of physical distance, avoiding crowded spaces indoor, and wearing masks in situations where I'm collected with other people that are not of my family in a third space. That's just a risk reduction measure. So I see mask wearing as a sort of as a personal protection measure that will probably extend for a very, very long time.
What do you think about inline, say at university level, the lecture theatres and getting things back in that space? Do you think that's something to be avoided or something to be embraced?
I think people can start getting back into college situations, absolutely. But again, it's about doing that in a way that we can maintain the maximum distance, but there's the logistics of universities. You can't rebuild infrastructure, and retrofitting and re-engineering whole campuses is not a possibility. So it's a matter of looking prudently and saying, look, what activities can we still do online? And in fact, what we've learned is that some activities that have gone online are great, and students are doing good with those. And we're learning how to educate through the different media. And then deciding then, okay, which of these things do we really need to bring back face to face? And we know this in medicine. You can't learn medicine on the internet. You need that. I remember when you were a reg in Galway, and Eamon Rogers and others and us chasing around. I learned more from you than I learned from any book or any professor. And that sort of apprenticeship process, particularly where there's a craft component in something, and that face-to-face learning is exceptionally important. But it's just.
Can I just say, at my end, that division between the student and the teacher, it's the essence of medicine is to be able to interact. And the president spoke elegantly yesterday about sustainability and resilience and stuff, and how when you're working together, and like the FREYER this year has been. So what do you think, will we be able to have a safe FREYER next year from the point of view? Do you think that by then that, or do you think that this is going to go on, we're going to be like, I suppose the question I'm asking now is, what time frame do you think is this going to last into the long term? A GP friend of mine was telling me last night that they do something, they give something like 6 or 8 vaccines to the average baby in the first 6 months now, or whatever, between, you know, and so on. I guess we're all going to be getting flu and COVID vaccines, coronavirus vaccines, and there may be more than one of them going into the long term, do you think? And how often do we need to get boosters?
They're all great questions for which right now there are no answers. And that's going to depend on what we do and what the virus does. But if you look at it, the history of influenza pandemics, right? You know, we still have the pandemic strain of influenza from 2009 as a predominant circulating strain around the world. But what we have through vaccination is we've got high levels of protection in our vulnerable populations, and the virus doesn't, we've adapted to that virus. And usually it's the next pandemic that fully replaces that previous pandemic strain. So I would see us having, I would hope, low levels of COVID transmission that will probably go on for a very, very long time. And I would see down the line probably that there will be some form of vaccination at some interval, and that's yet to be determined because we don't know how long current vaccines are going to protect. And already, you know, and I'm sure you're looking at this in cancer services, and countries are looking at extending the primary schedule, not giving a booster dose per se, but looking at those people with immunocompromised or people, very elderly people living in homes, and saying, given their immunologic response to the first 2 doses, maybe we should give those people a 3rd dose to complete a primary course. In other words, but the idea that fit and healthy people who've currently had 2 doses require a booster dose at this point, we don't have the evidence to support that. And apart from that, there's the ethical argument. How can we do that? I've likened it before, I got in trouble for saying it, but I'll say it again, that's like handing out life jackets on the Titanic, and you're giving some people 2 life jackets and not giving others 1. And you can argue that 2 life jackets are better than 1. But what you need to recognize in isolating that argument, here's 2 life jackets, is that there's someone standing next door in a developing country who has no life jacket. And we have to trade that off. And we have to look at equity in the context of that. So we have to be very, very careful and prudent around the whole idea of boosters. There are rational justifications for extending the primary course to a 3rd dose for some people. But that at the moment, the evidence for population-based boosters.
How long, do you have any evidence as to how long it lasts? You know, that, you know, is it, you know, how, you know, in the context of, you know, it's, say here in Galway, most people were vaccinated in January, I mean, the healthcare professionals and so on. Is it likely that the majority are going to be protected heading into deep into winter, do you think, Mike, or would you, do we have any evidence in that space?
All of the evidence so far would point to the fact that that protection will remain. And you can't just, we don't have a correlative protection yet in terms of, you know, blood measurement. You could just measure antibodies, but antibodies wane. And what we need to be able to measure is the innate immune response, the immunologic memory. And immunologic memory is not always mediated by your IgG levels in your blood. And all of the studies so far show that there is strong immunologic memory when you had that proper first 2-dose regime, or 1 dose in the case of J&J, and that memory is lasting. And each time the results come out, we get reassurance that the vaccines, particularly in people who've completed a full course and don't have an underlying immunologic condition, that they're maintaining that immunologic memory. But it remains to be seen. We know with coronavirus is that, you know, there can be reinfections even from a natural disease. So the possibility of reinfection remains. But then in that situation, we'd say, okay, those reinfections should predictably be much milder and not life-threatening. And then we have to decide at which point then, based on that epidemiology, would it be prudent or rational to introduce a yearly or every 2 years, sort of like with flu, some form of a booster. And again, that's going to depend on the evolution of the virus, because we would be developing then 2nd generation vaccines against the predominant circulating strain, or looking for vaccine targets that are conserved across all of the different variants. The goal, you know, we're still searching I mean, if you think about influenza, and you think of all the scares that influenza caused, we're still making influenza vaccine in eggs. We're using 70-year-old technology. We're still injecting hundreds of millions of eggs, and we're growing that vaccine every year using what is now, in medical terms, ancient technology. We need to move to the platforms like we've got now, the mRNA type platforms, and we have to be able to develop, what we've got investment now from Gates and others in the concepts of universal vaccination, a single dose of vaccine that protects you for life. So these viruses are so mutable, they evolve so quickly that, the second we may end up having a second generation of vaccines that, we could end up having vaccines that contain multiple strain protection. And then we might evolve to a broadly more protective universal vaccine. And that's going to depend, in a sense, on how much we're willing to invest globally in that defense. And right now, our collective investment, both public and private, when you think about what this virus has done around the world, and when you think that we're spending, trillions of dollars every year in military defense, and we're struggling in WHO to get $17 billion to vaccinate the world, I think we need to readjust as citizens.
Can I move you on to that topic then, right? And the one thing, just let me say in starting that topic, that your communication skills are exemplary. And for any young medics listening and so on, just a question, were you born with them, or did you work on it, or is it just experience makes it, or whatever? Just like, how does one acquire the ability to communicate in the modern world like you do, or what do you put it down to? You have a very good primary school teacher like I did.
I had great teachers throughout. I had a great science teacher, Austin Egan, who really gave me a love of science, and he communicated science in a way that was just so exciting and accessible. But I think, to be honest with you, I think we, as within Irish culture, we're very oral and expressive. And being able to tell a story is seen as a huge advantage. There's always a fella down the pub, and you don't want anyone else telling the joke except him. You'd wish people would tell him the joke so he could tell the joke, right? So it's not the joke, it's the teller of the joke, right? And I think there's a huge part of that.
So in terms of influencing, the World Health Organization, Trump and his pomp last year decided to pull plugs and stuff like that, right, from the point of where it's going. So how do you go about creating the kind of international, make the World Health Organization the single most important, value system or ecosystem for delivery of the healthcare? How do you go about doing it in the modern world now? What communications are necessary, and how does it function in that space in, say, South America, Africa, East Asia, or versus here? Because certainly the one thing that surprises me is, like, in Ireland, we didn't have much of an input from the World Health Organization until the pandemic arrived, and then suddenly you're on the TV screen every day or whatever. No, in terms of and in terms of really effective being able to transmit what needs to be done, it was clear that you knew what you were doing.
Well, we're a relatively small organization. I think the running costs of WHO are less than the running costs of the Presbyterian hospital in New York City. So we run on probably the less cost than a major tertiary referral center. So it's not, we're a very small band of people, hundreds of nationalities, but we aren't anything more than, we're almost like the AA club, the breakdown service. The World Health Organization is not us here in Geneva. The World Health Organization is 194 countries and their ministries of health coming together to make policy, to develop solutions together, to develop strategies together, and to try and bring the best minds and bring the best evidence so we can collectively come up with solutions for people. We're not in the curative services, we're not even in the preventive services. We're almost like a platform through which countries, individuals, scientists around the world can collaborate. This week we were in Berlin with Angela Merkel and Minister Spahn opening a pandemic and epidemic intelligence unit, a new office in Berlin. And that's going to be working with hundreds of organizations around the world on developing predictive analytics for the next pandemic. There will be 60 WHO staff in that, but that'll be amplified by hundreds, thousands of scientists, and so we're amplifiers. It's an amplification platform for global health.
And the funding model for that, Mike, just is mainly, is that through Europe or through Germany, or or through the World Health Organization?
For our unit in Berlin, it's mainly German funds. But when we look at our budget, and this is an interesting stat, 20 years ago, WHO was 80% funded from contributions by member states, assessed contributions. It was almost like the Netflix subscription, you paid every year, every month, the country's paid. Now we're 80% funded from what they call extra budgetary funds, which is donations from governments or foundations or philanthropies, which means WHO has become very dependent. We've almost become a subcontractor. And that really does constrain our ability to be strategic and to act independently, because you have all of this pressure to raise funds. You probably have it yourselves in the academic side. And I remember way back, John Flynn was trying to build the medical service there, and God knows there was an awful lot of hats been shaken around in various.
You never stop shaking your head.
And that's good, and it's healthy in a sense, because one should never, in a sense, one should never have enough money to be lazy or enough money to be arrogant. One should always have to sing for your lunch. But it has been a big problem for our organization, and certainly when the US threatened to withdraw, and they hadn't withdrawn, it was a threat to withdraw. It was a great relief to President Biden. Withdrew that withdrawal, and not as much about the money, but it was around the idea of global collaboration. And again, how many students and how many scientists and how many doctors and surgeons in Ireland have received part of their training in the United States. This was about losing a major partner in global health. This wasn't about the money. So, we wanted, and we will always, and this is one of the things I've had to learn, because I'm a bit of a fighter, and I've had to learn how to, be a diplomat and remain respectful, even when you're being broadly attacked in public, because we're a secretariat to those member states. And when they get angry with us, we just have to take it, because we see beyond that argument. We see beyond that tension. We see beyond that conflict, and trying to keep health for all at the center of our equation. And, I think we Irish we're good at that. We're natural activists, but we're also cutors, and we can sort of get our way through the difficult parts. We understand the complexity of these situations.
Okay, talk to me about the impact on the cancer programs as you would see it from your end, because it certainly has, the COVID pandemic has seriously destabilized cancer care. Particularly, I think, in the west of Ireland, but I think it's fair to say, Richard O'Leary presented data that it's, has impacted all over the country. Looking from with your World Health Organization hat on in terms of cancer and where we're going and what we need to do and the implications of COVID, etc. I don't know, do you have a few key thoughts on that?
Well, certainly it's had a huge impact. I mean, we've been doing these things called pulse surveys over the last 2 years and reaching out to all countries, looking at disruption of services. And there's been disruption on the provision end, but also on the utilization and demand end. So you've had a disruption of outpatient services, which is driven by a lack of capacity of the hospitals to deliver those services, because many staff are transferred into acute care. But also the demand side, people are afraid to go to their appointments, or there's no bus service anymore to go to that appointment. So you've had both impacts on that. Cancer services have been particularly impacted, particularly surgical services associated with cancer care. And screening services have been hugely disrupted in countries. I mean, screening, about 50% of countries, 45 to 50% report disruption in screening services. 20% of countries reported severe disruption, prolonged disruption in screening services. Now, the high-income countries have done better. On the face of it, yes, the images have been there, but high-income countries have had the ability to react. People like yourself and others who've been able to, engineer solutions for that. Low-income countries have struggled because they were already struggling and deliver basic cancer services, and that struggle continues. And remember, in this, when we think about cancer in terms of global burden, 2 in 3 of all cancers globally are occurring in low or middle income countries, not in high income countries. that's where we've seen an even bigger impact. And we were struggling before, Mick. It was, you know, the SDG is 3.4 is about reducing preventable death from non-communicable diseases. We were already struggling and reaching the goals there. So the pandemic has only added into that, because many developing countries are really struggling, because as incomes increase and as basic health indices increase and kids aren't dying of preventable diseases and people are reaching adulthood, now cancer and chronic diseases like hypertension and diabetes, which were almost seen as non-existent in developing countries, what's happening is that those are really presenting themselves as major costs in the health system and major causes of death. So yes, there's been huge disruption in hospital services. And again, I take my hat off to all of you, because, you know, I can't imagine what it's been like to both, you know, react to the pressure of the pandemic, as so many doctors and nurses have had to, you know, we've had anesthetists have become, you know, intensive care specialists, and, you know, endocrinologists have become, you know, respiratory physicians, and surgeons have become physicians again, as everyone worked together to try and, you know, meet that demand of the tsunami of cases. But then shifting those services in and losing beds and losing admissions, and then watching your own patients getting delayed into the system, it must have been very hard to witness.
One of the things that I certainly my take on the whole thing, but I'd be interested for your view on it, is that the cancer program needs to be separated from the emergency and elective programs. That it's so complex now to deliver a cancer program that you can't have it in competition with emergency programs. I mean, do you think that that's what countries are doing in the Western world, or would you have a view on that process?
I mean, there are also those trade-offs. What I would say to you is that what we need to be able to do is not run our health service like a low-cost airline at 120% occupancy, you know, which we effectively do in many countries. There's no elasticity left in the system, which means as soon as there's a major disruption, it doesn't have to be COVID. It can be norovirus in the winter or influenza season. It can be anything. All you need to do is just, you know, a feather can knock over the health system, not because the health system is weak, it's strong, but it's operating at it's over revved the whole time. It's like running an engine at 8,000 revs a minute. Yes, it's very fast, but it's also running beyond its design parameters, and then it fails. And when you run any, Sir Liam Donaldson, the chief medical officer in the UK, once said to me, I was based in Pakistan at the time chasing polio viruses, and he was the head of the global monitoring board for polio eradication. I came to a meeting in London, and I was there, you know, giving out about, you know, all the barriers and all the things we weren't getting done, and, you know, really externalizing the failure to eradicate polio into the system problems, you know. And he turned around to me and he said, you know, in any endeavor in health, the system, the machine delivers exactly what it's designed to deliver. So if you end up with people on trolleys, if you end up with people not getting access to healthcare and long waiting lists, that's a design effect. Your system is designed to deliver that outcome, because you don't have enough beds, or you don't have a properly trained workforce, or you don't have enough flexibility in the system, or there isn't enough money in the system, or as you said, you haven't isolated and protected certain parts of the system so they're not impacted by the emergency. And I think in every country, including Ireland, and people are going to have to take a hard look at that. Some countries, you know, Germany included and others, had a lot more give in the system. They were overcapacitated with ICU beds. They had a much higher ratio of consultants or physicians to population, particularly in the emergency care side of things. And they were able to weather the storm. They still had to weather a big storm, but it didn't disrupt routine services as much, because there was that elastic part of the system that could expand to absorb the hit of the tsunami of the pandemic.
What about the average accommodation type? I mean, we still have, you remember St. Anthony's, St. Enda's from our days together. And I mean, those wards, I mean, they should be consigned to museum pieces at this point, I would have thought, at a level. But from the point of view of the global health, like, would you be suggesting, like, should everybody have a single room with a toilet facility rather than shared toilet facilities or whatever in the Western world nowadays, or do you have a view on that?
I think our hospital systems need to be, in general, much more adaptable to different demands. And our way of bringing patients into the system, our whole way of triage and clinical management and the clinical management pathways, I think that's as important as the infrastructure. The infrastructure itself is important.
Yeah.
You know, but if you give me a very complex machine that's well designed, I don't know how to fly the damn thing, then I'm going to crash. So I think there's two parts to that. I mean, and I think particularly in cancer services, the workforce challenge is probably bigger than the design challenge, right?
Let's talk about that then. Let's talk about that. One of the challenges for me is there's a 16 million nurse deficit, and the nurse is the most important healthcare professional, but we seem to need a nurse to do nearly everything that needs to be done within the healthcare pathways at the moment, and we don't have enough nurses to expand our programs and do stuff. Do you have a view on that, or does it come into your radar as something that needs to be fixed?
No, it does, and you know, there's always this tension in healthcare delivery between the generalist and the specialist, and sometimes you see you can get super specialists and everyone does a certain job, and then you can automate that function and then train someone with a lower level of qualification to carry that out. And then there's the other thing where everyone can do everything. And there is a need for both. You have to be able, I think, particularly in cancer services, to have that ability to have specialists, for example, specialist nurses who really can engage in higher levels of practitionership in the system and as part of a team. But in Ireland, we have historically that divide. We have the doctor and the nurse. We even have the divide between the hospital consultant and the general practitioner. We have lots of walls that have been built over years. And they've been broken down now, and much more, you know, team approaches to clinical care with the patient at the center of the process. So patient-directed or patient-oriented care, where the system comes around that patient's journey through the system, rather than the patient being handed around in the system between different services. So I think we really need to look at that and how we're going to manage that. And that can't just be done by managers, you know, and sometimes we do that because we want to be more efficient, and we hand over that patient experience to the managers of the system. And I don't necessarily think, personally, it's a personal view, it's not a corporate view, that that's necessarily the way to go. I think we really do have to have a much more multidisciplinary approach to the management of the sick patient. We had it, my own son was admitted to your fine institution to one of the aforementioned wards a couple of weeks ago, and he was quite sick, and Chris Collins and Dr. Farnham there and the teams were absolutely superb. And just like to thank them from myself and from Maura, Tom's mum, for that. And one thing I know in Ireland is once you get into the system works. Just getting into the system is the hard part. It's getting on the motorway. That's where all the problems are getting off the motorway. Once you're in the stream of the system is very, very good at doing what it does. But there's a lot of inefficiencies in that, in terms of who's doing the care and what level. So again, workforce management, patient pathway management, and then the infrastructure around those teams and those patients, and all of it matters, because one thing affects the other. I remember there was a Japanese colleague of mine said they had massive traffic problems in Tokyo, and the big thing was they needed to build a big new motorway right through the center of Tokyo that nobody wanted. But then he introduced all kinds of things like apps in cars to manage traffic flow, and they had all kinds of different arrangements, and they put in place a whole series of different behavioral arrangements, regulatory arrangements, and I think they achieved the equivalent of a 6-lane highway by actually just making the existing system perform better. So we need to look at that, because sometimes there is a bit of a yellow ribbon syndrome, that the answer is always in the next big thing. And yes, sometimes that's the case. We see that with the Children's Hospital. You know, sometimes there is a need for a leap forward in infrastructure, but sometimes that's not what's needed, you know.
Well, all I would say is in my assessment of what's going on here and your son's care, it wasn't the staff or whatever else, but perhaps the infrastructure could do with a bit of a lift.
It could. But the people in those systems, I tell you, those words, and again, when you mention nurses, but covering yourself as regs, I learned what I learned in Ireland in medicine very often from those nurses in casualty.
As we all do.
You know, the nurse on a ward who would say, you know, I think you need to see Mr. O'Brien, not Mr. O'Flynn. And that was years of experience, you know, talking. And I think, you know, it's great to hear you affirming the primary role of the nurse. And that's, if you go to developing countries, that's even more acute.
Yeah. So that has to be a huge difference in terms of surgical provision of care internationally, with the lack of surgeons, say, in Africa, which you would. So can I ask you about that? You went to Africa at some point and did some, or you plan to do some operating, or what happened? Or
no, you said I was a surgeon. I never qualified as a surgeon. I was an aspiring surgeon, but I was actually on my way. I think 1990 to the Royal Prince Alfred in Australia, and I'd been accepted. I'd done my time in Scotland and done the first part of the surgical exams, and then I was a wanderer, and I got a job. I was accepted onto the Reg program at the Royal Prince Alfred in Australia, and I thought that was it. I was heading off there, but I did a detour, and I stopped at the Ibn al-Bitar hospital in Iraq, and ended up as part of that whole Irish contingent that were hostages in Iraq. And then I fractured my spine in a bad car accident there, and that was sort of the end of my surgical career. And I ended up back in Ireland, kind of, and it's to all those students who might be listening out there, anyone who thinks there's a big plan, there's no plan for anyone, right? I was probably sitting in Ireland, depressed, thinking there goes my career, you know, barely able to move. And I remember calling up Cecily Keller at the time, she's now in Dublin, who'd set up a health promotion department, and I basically begged her for work therapy. And I went into Cecily's department at the time and started helping with community surveys and doing different things. I said, well, if I can't be a surgeon, I'll be a public health physician.
What did you have to do then to become a public health physician, Mike?
Well, I from Cecily's advice, I went to Dublin, UCD, did a master's in public health. And then I went to the Public Health Laboratory Service, the Communicable Disease Surveillance Centre in London, which is now Public Health England. And they had a higher specialist training scheme in communicable diseases and public health, which was kind of a mixed training scheme of infectious diseases and public health. And I trained there. And it's interesting because when I went to my interview, I was the only person coming from a surgical background amongst all the interviewees. And I really thought I had no chance of getting it. And Norman asked me a question. He said, and it was a tough question, but he was giving me a chance to make my case. And he said, so tell me, what could a surgeon possibly bring to public health and epidemiology and epidemic response? You know?
Personality, I suspect.
And I will say I must have spent, it probably was only 3 seconds, but it felt like 2 minutes gobsmacked trying to think my way through it. And I remember saying to them at the time, I said, outbreak response is like surgery because you're making big decisions based on limited information. You don't have the time. You never have the time to get the perfect information. And you have to intervene, you know, in a very severe way in the life of an individual or in public health, in the life of a whole population. And there are consequences to that because you won't always get it right. And I remember Parnell Keeling saying to me once about appendectomies, he was saying, you want to be taking 1 in 20 out that are perfectly normal because you don't want to miss the one that's going to kill someone. And I remember one of the pathologists in Galway, after one of my attempts at a normal appendectomy, writing back a pathology report saying that this was the best example of normal appendix histology that he had ever had the pleasure to report on. But I think that taught me that idea that you have to be fast and you have to intervene. You have to be comfortable in making big decisions that have consequences based on not perfect information. And I think that links surgery with emergency response, you know?
You mentioned Cecily Kelleher. It sounds like she was a mentor of yours at a particular time. Do you still have a mentor? Did you have a mentor? Do you mentor people now yourself? Or how does that whole situation pan out in your current situation?
No, you need mentors. Cecily was certainly great about people. Mary O'Mahony was the deputy director of CDSC. She was Irish in London, and she was fantastic to me personally. And Mary's from Cork, and all the way through David Heyman, who was here in Geneva when I arrived here first, and people who guide you, and Liam Donaldson I mentioned before. There was Richard Cash at Harvard. I remember when I went, my first big lecture in the US was at the American Academy of Medical Sciences, whatever it was, huge thing. I thought I was going to give a lecture to 200 people, and there were 2,500 people in the auditorium, and I nearly ran away. You know, the Irish inferiority complex came out of me. I was having cold sweats, and Richard Cash, who was there, turned around, grabbed me, looked me right in the eye, and he said, "Hey, Mike, you're Irish." He said, "Tell them a story." And stood up.
You haven't stopped telling stories since, have you?
Indeed, and I think you need people like that in your life.
Yeah,
But I don't like mentorship from the perspective, you know, that's an inside track for people to fast track or get ahead.
Yeah.
That's not mentorship, right?
Sure.
That's nepotism, right?
Yeah.
Mentorship is about having people in your career path and with you or gone ahead of you that can guide you on that path. And support you when you've gone on the wrong path, or help you get back on the right path. That's mentorship. Right. And I think we should be proud of mentorship, but never let it reach a point where it becomes nepotistic. That's a destructive part of the process, you know.
And in terms of future-proofing the organization now, with regards to the World Health Organization, are there some more Mike Ryans coming through?
We've got some, as you probably have in your service, some brilliant people coming through. And as you know, the hard part of that is making sure that they're not crushed in the process, right? That they're able to come through that system with the right demands on them. And what we need to do is have a performance-based system. We need excellence in all of these fields. So this isn't about, you know, making a nice, easy place for people to exist. We need, in medicine and in public health, we need to be high performers, and we need to drive people to excellence. But we need to provide a positive, a safe environment for them to do that in, especially for women. And we need to create the opportunities and then put the demands on people who are properly resourced to deliver on those demands. And then we produce excellence. And I think that's, we've got a fantastic bunch of people here. I mean, and the great thing for me coming in the morning, it's the United Colors of Benetton here. We have people from all over the world, all walks of life. We have disabled people, able-bodied people. We have people from the LGBTQ community. We have a huge diversity of people. And it's that diversity that gives us our relevance, because we're not the World Health Organization in Geneva. We are in Geneva, 2,500 people from all over the world. And that's a very different thing, you know?
And one of the challenges, I mean, obviously there's been a pandemic for 18 months and that stopped most people flying around and doing all sorts, but you're still a displaced Irish person, as in the best sense in the world. You know, probably Joe Biden is a displaced Irish person by a few generations or whatever, it doesn't matter. So how does all that work for you in the context of, it sounds like you're in Pakistan, South Africa, you know, Berlin or whatever? Are you still an itinerant, or, you know, a traveler of the globe, or what? How does it work in the context of?
Well, I always present myself as an Irish national and a global citizen. So my dad was a seafarer for most of his life, so it's kind of in my blood. And I enjoy being abroad, but I'm pure Irish. I'm pure mule in a way, in the sense that you don't forget the strength of where you come from, and all the people that bring you to that point. I mean, God knows I've probably gone as close to going off the rails as many times in my life without, you know, special teachers, my mom, my friends, other people around me who've helped me. And anyone listening to this podcast will have exactly the same story. The minute you begin to believe that you're a product of your own wonderfulness, you're really, you know, you've reached a very bad point in your life. And understanding the communities. And I think people in Ireland, you know, you know that saying that it takes a village to rear a child, you know? I still think we have that sensibility in Ireland, and I hope to God we don't lose it in the coming years, you know?
I think I'll finish there. Unless there's something that you meant to tell us that you haven't told me or told us so far or shared, but I think as we've gone around the houses with the virus, where the country is going, and we started out with asking, would Mayo win the match next Saturday? So do you have a view on that?
You know, I've existed my whole life on the border between Mayo and Sligo. Half my family from Sligo, half my family from Mayo. Our mutual friend of ours, Sean Smith, probably you need to reach out to Sean and offer him a bit of counselling this week, and every other Mayo person who's waited for decades, right? Because it's probably not cancer services they need in Mayo this week. It's psychological services. I look, two great counties, Mayo and Tyrone, going at it, and but I'd love to see the curse lifted, quite frankly, for the Mayo part of me. And but who knows? Who can tell? But one thing I do love doing, I must say, and maybe it's just because I'm abroad, I still follow my old football team in Sligo Curry, the GA team. I still follow all the GAN hurling matches, and it's a great sort of definition of being Irish, the sports that we play. So, and I have one of my greatest joys is getting friends here. I have a big screen in my office. I love getting people into my office and showing them hurling matches, just to show them what the fastest and most exciting field sport in the world actually is, you know. So you can take the man out of the bog, but you certainly can't take the bog out of the man, mate.
I have your medal here. I'd like to give it to you in person when you're back at some stage, if rather than posting it or doing anything else. I think you've graced us with your wonderful presence and talked very frankly and very informatively, as you always do, about where we're at in the world with the pandemics and vaccines and processes and programs around healthcare, workforce planning, and particularly how to inspire the next generation of people who aren't quite sure how they're going to be the best in the world, but could be if they're given the opportunities or have the skill set that you have to create the opportunities. On behalf of all of us, I want to really thank you for your time. And I want to thank you for the inspirational leadership that you've delivered, and keep up the great work, Mike. Thank you.
Thank you, Michael, and thank you to you personally for all those years where we chased around after that white coat and in those aforementioned wards. It's a good job you were a tall man. We could keep an eye on it as you bounded around at that time.
It is the one thing that I would say is it's still as enjoyable as ever to be able to do that. So we've missed the student experience a bit over the last year, but hopefully we'll get it back.
All right, it's a pleasure and honor. Very glad to be with you all there in Galway.